Are we getting fancy or what? How about that for you? We have an intro and we have us here on the split screen. You get to see our faces rather than masks. I'd like to thank Matt Lindstrom for getting this all figured out for us. So shout out to Matt. Thank you so much. And yeah, I'm looking forward to today. We're going to have Dr. Thomas McClone, who's going to be speaking about breast health. But as we do once in a while, this is a foundation-sponsored event, and I'm going to have Sherry DeWalt give a little message from the foundation, talk a little bit about today's program and about the foundation. So, Sherry, it's yours.
Okay, thanks, Dr. Bird. So the mission of the CGH Health Foundation is pursuing healthier lives for people of the Sauk Valley. And one of the ways we do this is with our Growing Healthier program. So we have the speakers every month and our providers come and give you some information. And we're so happy to have Dr. McClone with us this month. In October, we typically focus on women's health. And so this year is no different. And while we're focusing on women's health, I do want to give a little plug for our mammogram program. It's probably one of the more visible programs that we have. And thanks to the Health Foundation, and you may not know this, no woman who has their mammogram done at CGH ever pays anything out of pocket. So either, their insurance might pay a portion. If there's something left over, the Health Foundation picks it up. If you don't have insurance, the Health Foundation picks up your screening mammogram. And so that's one of our programs. We also pay for PAPs under our Women's Health Initiative. And those just require a phone call to me and some prior arrangements. But you don't have to do anything special for your mammogram. Just make your appointment, come in, and we take care of all of the financial details behind there. I also want to remind everybody that so one of our big fundraisers of the year is coming up, and that's Delicious Designs. And you want to watch our Facebook page for more information about that. It's gone virtual this year, so we're still having an auction, and you'll bid online and take care of it that way. So I think bidding begins mid-October. But again, look for our Facebook page. Next month for our Growing Healthier speaker, we'll have Dr. Blasquez, and that'll be on November 5th at noon. Again, a Facebook Live program. And November is Diabetes Awareness Month, and so Dr. Blasquez is going to be talking about diabetes then. So thanks. I'm going to turn it back to Dr. Bird and let him get started.
Thanks, Sherry. Appreciate it. So, yeah, I'm really glad to have Dr. Thomas McClone with me today. And Tom is a general surgeon here at the hospital and has been on our staff for a number of years. And he's also on the board of the hospital, so he's involved in that way as well. Oversees the wound center at CGH, and we might have him back sometime to chat about that. But today, what I wanted to have him on for was to talk about breast cancer surgery, breast cancer, some new things that are going on with that, and just kind of pick his brain about that, as this is, this is a good month to have that conversation. So welcome, Tom.
Thank you.
Yeah, glad to have you. So I'm going to start with a pretty easy question, but I think people will be interested to hear this. How long have you been doing breast surgery for?
I did my first breast biopsy in 1976, so it's about 44 years.
Okay, you have a little experience under your belt.
A few.
All right, so here's the next question that follows from that. And yeah, you can go back even further than your career, but I'm just curious from your perspective how breast cancer surgery has changed over time. And what are some of the biggest changes you've seen in your career as far as breast cancer surgery goes?
Well, it's best, as my old professor used to say, to take an historical perspective on everything. Because as Bernard of Chartres in the 12th century said, we stand on the shoulders of giants, meaning we wouldn't be here without all of those who worked hard before us. And so breast cancer in the literature, and literature broadly, was first mentioned in the Edwin Smith Papyrus 5,000 years ago in 3000 BC. And back then, the only treatment they had for it was cauterizing the tumor, which was probably unsuccessful and painful. And that really didn't change much through the Middle Ages and the Dark Ages, partially because people didn't live long enough to develop breast cancer. So breast cancer really wasn't a big issue.
Right.
So as far as modern surgery for breast cancer, that really started in the 19th century with William Stewart Halsted, who was a professor at Johns Hopkins, and he would see patients in his clinic coming in with fist-sized breast tumors eroding through the skin. And back then, there really wasn't any good help for them. So he developed radical mastectomy as a cure. Now, multiple reasons why he developed this. The tumors he was seeing were huge, and there really wasn't any other treatment available.
Sure.
So he used this as a cure, and it did do well for some patients. Some patients died of bleeding because we didn't have good ways to control bleeding back then. Some patients died because the tumors had spread despite the surgery, but other patients survived. And so those are the ones that he studied to try and figure out what the difference was with those tumors. And he proposed that there was something different about the biology of those tumors that made them different.
Yeah.
His operation, though, was quite deforming. He removed the tumor, the breast, the muscles of the chest wall, so you couldn't even move your arm very well after surgery.
Was this pre-anesthesia, Tom?
They used chloroform back then for anesthesia, but he also experimented with anesthesia drugs. Not to his advantage, he became addicted to heroin and cocaine, but he used those in his practice, and those were the useful anesthetics back then.
Okay.
But this caused a huge deformity, frequently requiring skin graft. And into the early 20th century, this was the standard treatment for breast cancer. Back in the early 20th century, people were ashamed if they got cancer. They didn't talk about it with their family. They were loath to go in to see the physician because they didn't know what they were going to get. And until healthcare got organized in 1913 by the American College of Surgeons, who were the people who came up with the Joint Commission too, so everybody would be happy about that. Back then, breast cancer was pretty rare. Lung cancer was almost unheard of.
Yeah.
And the most common cancer issue was stomach cancer. Well, we almost never see stomach cancer these days because that got fixed by improvements in water sanitation and public health. But people now started living longer. And when you're living longer, now you can start developing other cancers.
Yeah.
So in the mid 20th century, people tried to come up with ways that were less invasive than the Halsted radical mastectomy. And an English surgeon named Mr. Patey developed what he called the modified radical mastectomy. And so he still took off the breast tissue and removed lymph nodes from the underarm, but he left the muscles intact. And for most people, this was an adequate treatment. But he still wasn't seeing early cancers like we see today. Yeah. So he was still doing major surgery, and it did lead to swelling of the arm because of the number of lymph nodes that had to be removed back then.
Okay. Yeah.
But about the time that he was popularizing that procedure, a surgeon in Italy came up with a new procedure. This fellow started doing quadrantectomy, or removing the part of the breast that was involved with the tumor, leaving the rest of the breast behind and closing that up, still taking out lymph nodes, and combining half of the patients with radiation therapy and half of them without. His name was Umberto Veronese in Milan, Italy. And he compared his outcomes to the British outcomes and to the American outcomes. Mr. Patey doing the modified radical mastectomy. And in this country in the 50s and 60s, we were still doing the radical mastectomy.
Oh, wow. Okay.
So Veronese, when I was in medical school, radical mastectomy was still the major treatment for larger tumors. A woman with a small tumor might get the modified radical mastectomy if your cancer surgeon was brave enough to go against the public thinking in the community. So It wasn't until Bernard Fisher, a fellow in Boston, promoted the Umberto Varnesi's approach and called it breast conservation therapy, where we would now remove just the lump associated with the tumor and remove the lymph nodes, and then do radiation therapy afterwards to treat the cancer.
When did radiation therapy kick in? When was that? When was that an option?
Radiation therapy has been used ever since Marie Curie won the Nobel Prize for describing how radium interacts with tissue. She's one of the few people ever to win a Nobel Prize in physics and then later again in chemistry. So she was a pretty remarkable person.
Yeah.
But her fingers were burned by all the radium that she handled. We didn't really know that radium was dangerous until the 1930s. And people in Colorado, where I grew up, used to go into radium mines to breathe the air to kill their tuberculosis, thinking it was healthy.
Wow.
So they got radon that killed their tuberculosis, but then they developed cancers of the lung.
Oh,
So
wow.
that wasn't a good idea. So radiation therapy had a bad reputation in the 60s because back then we were using cobalt, which was a fairly indiscriminate form of radiation. And now we've got much fancier radiation therapy machines
Sure.
that can limit the dose of radiation that you get, target it much better. And so combining that, the advances in radiation therapy with Fisher's idea of breast conservation surgery, you now had a much better way to treat breast cancer with preservation of a woman's body image without having to totally deform them by amputating the breast. The flaw in this whole thing, though, is that surgery only treats the localized disease in the breast. It doesn't treat the body where you may have microscopic disease in the bloodstream or something like that. And what we want to know is, what is your risk of having breast cancer outside the breast? So a surgeon in New York, Armando Giuliani, who'd been treating melanomas, took what he was using for melanomas called sentinel lymph node biopsy and developed that as a technique to try and tell us what stage your breast cancer was at. Was it in stage 1, where it's just limited to the breast, stage 2 in the breast and the underarm area, or spreading to the rest of the body? And the
So you
sentinel
do
lymph
the,
node biopsy.
when you did the sentinel node, if I
Yeah.
understand it right, you're not taking as many lymph nodes out, so there's not as much of tissue that's being removed. You're going to
Right,
one
not
area.
as much tissue, and the arm function is much better after that.
Okay.
So those are the things that have changed during my era of starting from 1976 till now, at least surgically.
Yeah. So when did the transition go into the sentinel nodes? What year, well, one time was the sentinel node happening in your career?
Giuliani proposed it back in the late 80s. I started doing it in 1990, and it became fairly widely accepted in the mid to late 90s.
Okay.
Now, even some surgeons, depends upon what part of the country you live in, some surgeons still do modified radical mastectomy for all tumors. So in the South, especially, they're still very conservative in their approach.
Yeah.
And in other places where you don't have access to radiation therapy, people will opt for mastectomy.
How about for you now and the rest of the surgeons? When would a woman have the lumpectomy versus this modified radical mastectomy? What differentiates the patients that are going to get one of those two?
Well, I occasionally have patients who actually come in and request a mastectomy. They say, I want to get it off. I don't want to worry about cancer coming back in the breast. So occasionally we will still do that. If someone has a large tumor that can't be managed otherwise, then they would have to do that. But for women who have tumors that are less than an inch in size, we can almost always do breast conservation therapy and just remove the lump and do a sentinel lymph node biopsy. For women who have larger tumors, we will frequently refer them to the medical oncologist first and have them do what we call neoadjuvant chemotherapy to shrink the lesion down.
Okay.
And if they have the neoadjuvant chemotherapy, then again, later we can manage it with the minimal surgery, because we're just treating the local disease. We're not treating the whole body.
Right. Right. Okay. Yeah. Good. That makes a lot. That helps me to understand that better. So in addition to surgery, and you just alluded to that. There's a lot more going on in addition to the surgical part of that in terms of surgical oncology, radiation oncology, and that has changed quite a bit too over the years. Not all breast cancer is the same, I think is what over time that we're learning in the medical community. Can you speak to some of the recent changes in our understanding of how to treat breast cancer from from an oncologist standpoint, from a cancer doctor standpoint, and a radiation oncologist standpoint that have changed in the last 10, 20 years?
Well, there've been a lot of changes in the last 40 years, especially with our board examinations, which we take every 10 years. The questions would remain the same, but the answers would keep changing because of changes in technology and science and all of that. When I first started treating breast cancer, we would remove the breast tumor and multiple lymph nodes, and we didn't know much about the biology of the tumor. We didn't know how to assess whether or not the tumor had estrogen sensitive reactions or anything like that. If the cancer spread to the lung and the bones after surgery, then frequently the patient would be referred for chemotherapy. And if chemotherapy failed, and this is still in the early 80s, we would go ahead and remove the ovaries and the adrenal glands to get rid of the body's natural sources of estrogen hormones.
Okay.
And that was a pretty invasive procedure, number one, and had a lot of physiologic side effects. We found out at that time that some people got better and some people didn't, and we didn't know why, because it wasn't until the early 80s, mid 80s, that we finally got a test that could tell us whether or not a tumor had sensitivity to treatment with estrogen blockers. But we didn't have an estrogen blocker then anyway. All we still had was remove the ovaries. So in the mid 80s, one of the biggest changes in breast cancer management in my lifetime occurred, and that was the use of tamoxifen.
Okay.
And
that was the mid 80s. Okay.
Right. Tamoxifen, what we had is we were able to test the individual cells to see if they had sensitivity to estrogen. In other words, do they have a thing called estrogen receptor activity? And then we were able to test the cells for whether or not they'd have a sensitivity to drugs that blocked that. So the development of this drug called tamoxifen and subsequently other drugs to block the effect of estrogen on tumors was probably the biggest change in what changed our ability to treat and give long-term remission or even cures for breast cancer. And starting in 1974, a PhD scientist named Mary Claire King started studying breast cancer genetics as well. And we're making progress in breast cancer genetics now. She started this in 1974 and was sort of poo-pooed by her fellow scientists, saying it's such a complex issue, you'll never find anything good out about genetics. But in her work, 16 years after she started it in 1990, she found a gene called BRCA. And there are two types of BRCA, BRCA1 and BRCA2, that caused cancer to occur in families. So this would be Gilda Radner had this.
Did she really? Okay.
Yes, that's Gilda Radner had the BRCA gene, and so did that actress who was married to the action guy, whatever. I'm blanking on who it was, but the one who's popularizing bilateral mastectomy now as a treatment for cancer.
Oh yeah. I know you're talking about. She was married to Brad Pitt.
Brad Pitt's wife. Yeah.
Yeah.
So this is all the work of Mary Claire King in 1990, when she described not only where the gene was on chromosome 17, but she described the protein that the gene made. And the protein was what's called a tumor suppressor gene. In other words, if you develop a change in your cells that causes you to get ovarian cancer or breast cancer or what we call primary peritoneal cancer, this gene is supposed to suppress that. It doesn't function in these families who carry this gene. And so they get very aggressive tumors very early in life. Only 1 in 8 women will develop breast cancer in their lives in this country, but out of that, 1 in 400 patients have this breast cancer gene. So it's not important to the population at large, but it's very important to these individual families who carry the gene. So we have to find other ways to treat the illness scientifically, and we've gotten a large number of studies now to discover different genes and how these genes work. There's a genetic assay that uses 20 different genes to look at things. The Dutch have another one that looks at I think up to 40 genes, and we can begin an era sort of personalized medicine by using these genetic tests to see whether or not you'll respond more than just to estrogen receptor treatment, but even to chemotherapy. And we found that certain subsets of people will respond to chemotherapy. And they even have a test now for human epidermal receptor number 2 called HER2, that if you are HER2 positive, we can give you an antibody treatment to breast cancer that doesn't give you all the side effects of chemotherapy. It doesn't make you lose your hair and all of those things. So we do have some ways to personalize the treatment of breast cancer in the earlier stages 2 and 3, that we didn't have before. But we don't have the really totally personal. We'll treat every individual.
We're not quite there. We're not entirely there yet.
We're nowhere near that.
So there, and if I remember right from tumor boards, there are some women that do they even have like whatever you're going to do in terms of lumpectomy and surgery, and they may just go on tamoxifen?
That's a very common thing. Is especially if you're over the age of 75, we usually do not treat you with radiation therapy. If we've got clear margins with normal tissue completely surrounding what was taken out at surgery, and they are estrogen receptor positive tumors, then we'll frequently put them on either tamoxifen or the newer drugs, which don't block the way tamoxifen binds to the cells, but actually block estrogen from being formed in the body. Okay. So those are called aromatase inhibitors, and they're more commonly used in women over the age of 70. Yeah.
Yeah, it just seems like over time, yes, it's breast cancer, but that breast cancer, you have breast cancer, and then you have all these different subtypes of it. And based upon those subtypes, there are a lot of different ways that those get treated. And it's just really, whenever I hear you guys talk about it, these tumor boards, and Dr. Ali Khan breaks out his algorithms of the different directions you go based upon what kind of receptors are positive or negative and how large the tumor is. And even some stuff I remember hearing about that more and more, even the size of the tumors, not as important as sometimes what the receptors are.
Receptor status is very important. It tells you how well differentiated or how close to normal the tumor itself looks. And if your receptor status is negative, you do have a more aggressive form of disease. If your HER2 is positive, you have a more aggressive form of the disease. If your estrogen receptors are positive, you have the what we call type A, which is the type that we like to treat just with hormone receptor antagonists for 5 years, or in some cases, they're going up to 10 years now.
Yeah. So this all sounds really good. So what does that mean for women, and a few men, but mainly women who get breast cancer? What are we seeing in terms of how do they respond to this? What are we seeing in terms of life expectancies and remission and or cure nowadays with breast cancer, Tom?
Yeah, I just say I've only seen 2 men with breast cancer this year. The rest of them have been women. And what we talk about with breast cancer is what is your probability of living 5 years after surgery? We call that 5-year survival. And today, if you have a stage 1 breast cancer, it's confined to the breast, not in the lymph nodes, and it's small, your chance of living 5 years is 91%. So breast cancer used to be a fatal disease for most patients. Now it's 91%. In the 1950s, if you had stage 1 breast cancer, and this is before tamoxifen and good chemotherapy, your chance of living 10 years was only 50%. Now we have a 10-year survival rate of 85%.
Wow.
For people with stage 1 breast cancer. It's totally changed since the 50s. And I blame a lot of that on the use of tamoxifen. The development of estrogen receptor testing and tamoxifen is a huge breakthrough. But there are other things that have allowed this to happen. Mammography has gotten much better. When I was a kid, I went to a science fair where I also got an iron lung because polio was still around back then. We had epidemics before the COVID one. At the science fair, there was a mammogram, and really it was just like a chest X-ray, but done of a breast. And so it could see tumors that were big and were different than the surrounding tissue in a fatty breast, but it was not what we would consider a mammogram today.
Yeah.
We've developed a thing called fine screen mammography and 3D mammography, and even MRI that has made us able to diagnose cancers at a much earlier and more treatable stage.
Yeah, I'm going to go off script a little bit. One of our listeners sent us a question about do mammograms save lives?
Mammograms do save lives, but when you say that, everybody says, "But I know this person who had breast cancer. She was only 36 and she was dead 2 years later." Well, the mammogram is not going to pick up the most aggressive tumors. Mammogram is intended to help populations have more people get diagnosed earlier, get treated earlier, and survive longer. So mammography does save lives for the population as a whole. But when you look at an individual, it's not going to catch some individual tumors that are sadly very, very aggressive. And those are the ones that we don't have any good screening tool for it at this point. But mammography saves lives for when you apply it to large numbers of people who get screened, but it doesn't save the individual life of somebody who has an aggressive, rapidly growing tumor.
Right. Okay, so what flows from that in my mind is, for mammograms, is when you have a mammogram, you don't want it to be positive. So in other words, you don't want to get breast cancer in the first place if you can avoid it. What are you learning? What's the literature saying what women can do to try to reduce their risk of getting breast cancer in the first place?
There are a number of things you can do. One is to be born with the right genes.
Okay.
And you don't have a whole lot of control over that.
No, not so much.
And the other is to get regular screening mammograms so that we know whether or not anything abnormal is developing in the breast. But there are some common sense things too. You want to avoid excessive exposure to estrogen. So you shouldn't eat, red meat 7 nights a week, that sort of thing. You want to have a healthy diet that is low in animal fats, and you want to have a healthy diet that gives you good exposure to grains and all of that sort of thing.
What's the deal on breastfeeding right now? What's the latest on
breastfeeding that? Reduces your risk of breast cancer significantly. So breastfeeding is one of the things that interrupts the cycle of growth and development of the breast, makes it go through what we call hypertrophic cycle. In other words, it starts doing its job, the breast gets bigger, it makes all of the milk, and then after you're through, when you've weaned the child, you don't breastfeed anymore, the breast involutes, and so it goes through a natural shrinking of the breast tissue. And in many cases, the breast becomes less dense after that. We know that dense breast tissue is a risk factor for developing breast cancer.
Yeah. How about what role, when you mentioned estrogen, what role does body mass index, body weight play into breast cancer risk?
Well, keeping a low body weight is important, because what happens when you have a large amount of body fat is that fat not only stores excess estrogen in the fatty tissue, but fatty tissue can also make estrogen. And so even if you're postmenopausal and your ovaries have quit, if you have a large amount of fatty tissue, you're getting hot flashes. That means your brain is sending out signals to tell your ovaries to make new estrogen. Well, it's going out to all the cells in your body. Those hormone signals are going out everywhere.
Yeah.
If you have a large amount of fat, you are going to make some estrogen in your fatty tissue and give constant stimulus to the breast tissue with that.
Okay. Yeah.
So a
Good.
healthy diet, exercise is really important in
Yeah.
preventing all forms of cancer. Smoking cessation, smokers get more breast cancers than non-smokers because you're exposed to cancer causing agents then.
Yeah. Yeah. Two final questions. First one is, what percentage of breast cancer is genetic versus environmental? Any sense on that?
Well, 1 in 400 people have the BRCA gene. So we know that that's a genetic thing. Every other breast cancer we basically call sporadic, unless you have a thing called Lee-Fraumau syndrome, which also is a breast cancer and colon cancer related gene. But within 20 to 25 years, we will probably find out that there is a much larger number of breast cancers that are what you would call genetic. In other words, linked and run in families and that sort of thing. We know that breast cancer runs in families who do not have the breast cancer gene. So the biggest risk factors when you see someone in the office for their initial appointment about an abnormal mammogram or any breast problem and including breast cancer, we ask about family history. Do they have a family history where somebody has breast cancer? Did they have breast cancer at an early age? Do they have multiple family members with breast cancer? Do they have a mother or a sister with breast cancer? Especially grandmother and aunts are not quite as important as far as those genetic linkages go. But there are definitely genetic factors, but we don't understand them because you're getting into an area called systems biology. Then that's the purview of mathematicians and geneticists and
We'll leave them be.
supercomputers.
Appreciate the comment from one of our viewers there. That was very nice that she's learning a lot from this. So good. And the follow-up question, the final question for you, Tom, because we could talk about this stuff for a long time. But, we try to keep this relatively brief. You kind of alluded to it, but in your mind, what is the future of treating women, diagnosing and treating women for breast cancer?
Well, in the short term, it will be improved mammographic techniques and improved access to healthcare. The foundation lets women come in and have free mammograms. That is a huge thing as far as detecting tumors early. The other thing is you have to get rid of the fear of cancer. A lot of people don't get a mammogram because they're afraid they'll find out they've got breast cancer. But the earlier you get that mammogram, the better it is. So the short term is mammography. Do good mammography, get access to mammography, and then have access to physicians and physician extenders who will get you referred to the right place for treatment. Long term, Monica Morrow, one of the foremost breast surgeons in the world, says that the way we treat surgery right now, the way we treat breast cancer with surgery right now, is like trying to treat it with a hammer. We are treating local disease as surgeons, not a systemic disease in the patient. And I think in another 50 years, there will be a very, very limited role for surgery in breast cancer treatment. Okay. And we will have biologic agents designed after we do a biopsy. We'll test your tumor for its genetics and maybe test all of the genes in those tumors and give you combination of medications, of antibodies and other forms of treatment that will treat the breast cancer without ever having surgery.
Yeah.
But that's a ways off. We don't know
Yeah.
enough about the genetics of the
Yeah.
disease, and it's not like BRCA where there's one gene that went bad.
Right.
In breast cancer, there probably are 30 genes interacting, and that's 2 to the 30th powers of combinations of potential. So it's more complicated than we can address right now.
Yeah, got it. But what I do really like what you had to say, Dr. McGlone, was about right now, probably the most important thing you can do from a population standpoint is to have more people do the mammogram, get screened, so that we can pick up folks earlier on. That's really valuable to hear that, and I hope our viewers are taking that in, and as they share with their friends and others, they keep that in mind. Yeah. So, and thanks again to the viewers who are kind of piping in that they're enjoying what you have to say. This has been great. I appreciate all the great information. If you know Dr. McGlone, you know that he is a fount of information. Knows more more about stuff than I could ever have.
I've been called other
forgotten
things
more
too.
stuff than I know. Let's just say that. So anyhow, great to have you on, Tom. Thank you so much. We're going to have Dr. McGlone back sometime to talk wound center too. But thank you so much. Great to have you,
Thank
Don.
you.
Yeah. Thank you so much. And then I'm going to kind of finish up here with just some COVID stuff. So as far as COVID goes, here are our numbers right now. The county has had 811 cases, 21. Oh, there we go. Thanks. Oh, hey, Matt, thank you. This is awesome. So you can kind of see where we're at in the county in terms of what's going on. And in the hospital right now, as of this morning, we had tested 6,349 people, of whom 387 were positive. Just as a point of reference, in the last 24 hours, 8 were positive. 24 hours before that, 11 were positive. 24 hours before that, 10 were positive here just at the hospital. So that's still going on, and we've tested 5,872 people who have been negative. So I just want to give you kind of a sense of where things at. I am reading some stuff now about some monoclonal antibody work, which is kind of like it's a form of treatment. It's an immune system treatment to try to take care of some of these infections that some companies are working on. That there's some hope that may be helpful for people who actually get COVID to be able to treat them. I wouldn't be surprised if in the next few months that becomes available. I think most of you know about we're in region 1, which is kind of from Rockford down through a little bit past where we're at. And that because of the number of 3 consecutive days being greater than 8% positive tests, that we've had some mitigation measures that are put in place that start on Saturday. So yeah, that's a bummer. No indoor restaurant or bars. Outside, you can eat outside at these restaurants, but you have to close by 11. And that was easier in the summer, but we're getting cooler out. So, boy, if I had a space heater, I'm sure a lot of restaurants would be looking for your space heater, particularly those ones that are kind of above your head and come down. So, boy, I sure hope that we can get out of this mitigation soon so that we can have a little more freedom in those kind of places. But I completely understand why it's being done. Being done to try to reduce the number of cases here in the area. And one final thought, unless there's other questions here, and I don't think there are today, I think most folks were pretty captivated with what Dr. McGlone had to say. Let me just check my phone here to make sure. Oh, the woman we couldn't come up with who had the BRCA mutations was Angelina Jolie. So I got that in there. And then one final thing that I just leave you with. I don't know if I was reading in a book this week that the chances of me being here, you being there, and listening to what I have to say, what Dr. McGlone had to say today, basically to be alive, is 1 in 400 trillion. I can't even fathom that. But I just say that to say that every day that we can take in the world and breathe fresh air and go about and just enjoy what we enjoy. Pandemic or no pandemic is a great day. So I leave you with that thought. Thank you for listening. Next week, we're going to actually do a little field trip and go and take a look at what we're doing to build out what we're going to have as a inpatient psychiatric unit. So looking forward to showing that with you next week. We'll go at noon next week, next Thursday. So until then, have a great week, and thanks for listening. Bye.